Good evening and welcome. I'm Vanessa Hoffman, Program Coordinator for Research and Education at the Bladder Cancer Advocacy Network, Beacon. Tonight we present Chemotherapy and Bladder Cancer, the fourth webinar in our spring series on treating bladder cancer. I'd like to do some quick housekeeping before we get started. Take a look at the left side of your screen if you're having trouble hearing, and also for the WebEx tech support. Please note that if you have questions as you think of them, please type them into the Q&A box located on the bottom right of your screen and select to send them to all the panelists. And additionally, this webinar is being recorded and will be available on the Beacon website along with the presenter slides in approximately within 2 weeks. Now I would like to introduce our distinguished speaker. Dr. Walter Stadler is Professor of Medicine and Surgery, Associate Dean for Clinical Research, and Director of the Genitourinary Program at the University of Chicago Medical Center. He's an expert in not only bladder cancer, but also prostate, kidney, and testicular cancers. He concentrates on the use of chemotherapy, immunotherapy, anti-angiogenic therapy, and molecularly targeted therapy for patients with locally advanced or metastatic disease. His research focuses on developing new treatments for these urological cancers. He's also looked at developing molecular and imaging markers to predict the response to various anti-cancer therapies. Dr. Stadler has authored and co-authored more than 160 articles in medical journals. He will speak for approximately 15 to 20 minutes, and then we'll be able to answer questions for about 15 minutes. I will read out the questions, and once again, you're welcome. Please type your questions into that Q&A box as you think of them. So let's get started.
Hi, everybody, and thank you, Vanessa. It's wonderful for everyone to be here this evening, and I thank you for sharing some of your time here tonight. So my job is to talk a little bit about what we do with chemotherapy and bladder cancer, and probably more accurately to talk a little bit about drug therapy and systemic therapy, for patients with this disease. Now, as many of you know, and certainly as you may have heard on some of the other webinars that were presented, the bladder and bladder cancer present us with a anatomical problem, at least as far as cancer and spread of cancer are concerned. As each of you recognize, the bladder is in essence a balloon that sits in the pelvis that allows us to store our urine until it's time to evacuate in, let's say, a socially appropriate manner. When cancer develops in this organ, it essentially develops on the inner lining of this balloon and the inner lining of this container. And depicted on the right side here is a blow-up of what this might look like in cross-section. Now, what's relevant here from a patient perspective is that a cancer that may develop on this lining does not have to grow very much in order to gain access to the blood vessels and the lymphatic vessels, which sit in what is termed here the muscle and the peritoneum. In fact, the actual distance from that initial layer in which the cancer develops to the muscle is less than 2 or 3 millimeters, and thus just a small amount of growth of the primary tumor gives the cancer access to these blood vessels and lymph channels and gives the cancer the propensity, or more accurately, the ability to spread to other areas within the body. Now, one of the challenges for, certainly for both patients as well as physicians treating this disease is that our capabilities for drug treatment have unfortunately not advanced dramatically over the last 2 or 3 decades. The initial combination chemotherapy for bladder cancer that has spread is a combination of 4 drugs: methotrexate, vinblastine, adriamycin, and cisplatin, abbreviated typically as MVAC or MVAC, was first reported to be effective in this disease in 1985. In 1997, I contributed to some of the what is now known activity of gemcitabine in this disease, and participated in some clinical trials in the late 1990s demonstrated that the combination of gemcitabine and cisplatin is similar to that seen with traditional MVAC. To be honest, since that time, we have tested many different regimens, combinations, and drugs, and have not yet found anything that improves on these 2 treatment regimens that were reported, as I said, almost 2 or 3 decades ago. What we can expect in patients who have bladder cancer that has spread from the bladder to other areas of the body is that about half of the patients, maybe a little bit more, will have a dramatic shrinkage of their cancer with treatment, and this shrinkage is associated with improved symptoms as well as improved survival. About 10% of patients will have a complete response, a complete disappearance of the cancer, at least using modern CT imaging, and about 5% of patients are cured of their disease. The average survival of patients with metastatic cancer, though, is only on the order of 14 months. Remember, though, that average means that half the patients do less well than that, and half the patients do better than that. And as I stated, about 5% of patients with metastatic cancer are cured with our current chemotherapy regimens. Now, when we see these patients, since we have essentially 2 standard regimens, what do we discuss with a patient? What we discuss is that the combination of gemcitabine and cisplatin, or the 4-drug combination of MVAC, are appropriate and standard treatments. The toxicities of these 2 regimens are actually quite similar when one uses modern supportive care, but there are potential cardiac problems and mouth sores with MVAC that tend to be less significant with gemcitabine cisplatin. The major toxicities of both regimens include low blood counts and risk for infection, fatigue or tiredness, nausea, and neuropathy or damage to the nerves, which can lead to some tingling in the toes and fingers, as well as to hearing loss. And importantly, from the cisplatin, one can have kidney damage. Now, because of the kidney damage potential, many practitioners and oncologists substitute carboplatin for cisplatin. Carboplatin is a very similar drug, but does not have the problems with kidney and neurologic toxicities, or at least those toxicities are much less significant with carboplatin. However, carboplatin tends to have more problems with low blood counts. Carboplatin is probably less effective than cisplatin for patients with bladder cancer. The data supporting that statement is, I would say, somewhat soft. And the significance of this difference in patients who have metastatic cancer is somewhat debatable. Importantly, and I will get to this in a minute, when we are giving chemotherapy to patients who have locally advanced disease and who we are planning to conduct some kind of surgery, should not be used because of the probable less efficacy or lower efficacy of carboplatin compared to cisplatin. The obvious question that comes up with the numbers that I've just presented is what should be done if the initial chemotherapy is not effective, or if the initial therapy is effective and then the cancer begins to grow again. Unfortunately, there is no standard of care for these situations. We can see tumor shrinkages or responses with a variety of drugs that I've listed, including paclitaxel, docetaxel, and pemetrexed. How important or meaningful these are for the patient in terms of improvement in quality or quantity of life is highly debatable. And it is thus my opinion that for patients whose disease continues to grow despite initial standard therapy, that clinical trial participation in which we're trying to identify new and better drugs is preferred. Now, what I list here is the title page from a New England Journal of Medicine article that established the role of chemotherapy for patients who have localized bladder cancer and who are candidates for cystectomy or for removal of the bladder. Remember that I showed you in that very first slide that once a bladder cancer begins to invade into the wall of the bladder itself, there is an extremely high risk that the cancer can reach the lymph channels and blood vessels and spread. And in fact, we know that patients with muscle-invasive bladder cancer have a high risk of recurrent, often fatal disease following primary surgery. As I explained to my patients, a cancer that comes back after surgery comes back not because the surgeon made some kind of mistake or that the surgery was inadequate. The cancer comes back because even at the time of surgery, microscopic cancer cells had spread to other areas of the body, and these over time then grow and provide us with the problem. It is thus in this context that giving chemotherapy around the time of surgery has become an accepted treatment for many of the cancers that we treat as medical oncologists and surgeons, and the article listed here establishes that principle for bladder cancer specifically. In this trial, about 300 patients were enrolled over the period of 11 years, and the objective of the trial was to assess survival of patients treated with surgery alone compared to surgery preceded by 3 cycles of MVAC. In the next slide, this shows the survival of these patients, demonstrating a clearly improved and better survival in patients who received the chemotherapy than those who received only the surgery. Now, the absolute improvement in survival does not look that great, but to be honest, this improvement is similar to what we see in breast cancer in women with locally advanced breast cancer who are candidates for chemotherapy either before or after their mastectomy. Unfortunately, these data have been poorly adopted, and the majority of patients who undergo a cystectomy do not receive any kind of chemotherapy, and in fact, historically, only 5 to 10% of patients receive such treatment. When this is looked at a little bit more carefully as to why this might be the case and whether the kidney function, which prevents the use of cisplatin, is an explanation, many investigators have found that this really boils down to physician and patient choice, and not because there is any kidney or other problems preventing the use of chemotherapy prior to surgery. Many individuals and surgeons will talk about using chemotherapy prior to surgery, in which we call neoadjuvant chemotherapy, and compare that to adjuvant chemotherapy or chemotherapy given after the surgery. Although we can read through the various advantages and disadvantages of the two approaches here, in my mind, the bottom line is that with adjuvant chemotherapy or chemotherapy given after surgery, a survival benefit has not been clearly established in clinical trials. And importantly, patients are less likely to receive the intended chemotherapy after surgery due to postoperative complications. So, in conclusion, when we talk about bladder cancer and chemotherapy, I tell my colleagues that perioperative or around surgery, cisplatin-based chemotherapy improves survival, and that the best data for the use of chemotherapy in this setting is prior to surgery or in the neoadjuvant setting. The use of this therapy is underutilized in the community. We know that not everyone can safely receive the chemotherapy, so we don't know what the ideal utilization rate may be, but it is certainly greater than the 5% that currently receive it, but probably less than 80% of patients. We know that gemcitabine and cisplatin, or the 4-drug combination of MVAC, are standard for metastatic disease, and that carboplatin-based therapies in the metastatic setting is a reasonable option. Unfortunately, there's no good standard therapy for patients in whom the initial treatment is not effective, and therefore it's pretty obvious to state that the current standard for metastatic bladder cancer is inadequate, and we truly need to continue to support our clinical trials to improve on what is, obviously not appropriate for either, patients, families, or the treating physicians. So I will stop there, and we'll begin to answer any specific questions. Vanessa, do you want to lead this and read the questions out, and then I answer, or how would you like to do this?
Yes, exactly. Thanks so much for your presentation. Let's get started with the questions. For the first one, the person asks, do you recommend chemotherapy with a stage 1, grade 3 patient with mild invasion into the lamina propria?
So this is actually a relatively sophisticated question, so thank you, Mr. Grieco. Hopefully I'm pronouncing that correctly. The staging system that I presented, if you were paying attention, revealed invasion into the first layer underneath that epithelium or the inner lining, and that's called the lamina propria, and that staging is called T1. When the cancer spreads into the muscle itself, it is called T2 or T3 if it invades into the fat. The clinical trial that I presented for neoadjuvant chemotherapy included only patients with T2 or T3 cancer. In other words, it excluded patients with T1 disease. And importantly, patients with T1 bladder cancer have pretty good outcomes with cystectomy alone. Typically, 85 to 90% of patients will be long-term survivors and cured of their cancer. So typically, I will not recommend chemotherapy with a T1 cancer.
Okay, thanks so much. For the next question, it says, can a tumor grow into the wall and not be noticeable on the inner bladder wall?
So this would be distinctly unusual because the cancer all starts on that inner wall. And so there is almost always a primary tumor in that location. Now, there are a couple of situations where it may be difficult to detect that primary tumor. Those include situations in which the urologist or the surgeon has removed the tumor and there are additional tumor cells left behind in the wall, so to speak. The second situation is that there are locations within the bladder that are just technically difficult to see with the cystoscope, which is the instrument that's placed into the bladder and looked around. So some of the areas in the bladder just are more difficult to visualize. And the third is that this lining that exists on the inside of the bladder also exists in the tubes that lead from the kidney to the bladder, which are called ureters, and also exist on the inside of the kidneys. And sometimes we get these same kind of cancers, which are technically called urothelial cancers, arising in these ureters or in the renal pelvis, and they may be difficult to detect.
Okay. For the next question, it says, what role does hyperthermia play with chemotherapy treatment in early-stage bladder cancers?
So a number of individuals have attempted to improve chemotherapy or treatment of cancer with heating of the organ that is being treated. This is called hyperthermia. Now, this is in some ways a somewhat slightly different concept because here we're trying to address the local problem, and there are a number of ways of addressing the local problem. One can do surgery, one can do a combination of chemotherapy and radiation in the invasive setting, and in the non-invasive setting, there's a number of drugs that can be placed inside the bladder for treating the localized cancer. What I've been talking about tonight is drugs that go into essentially the veins and go throughout the body to attack those cancer cells that have left the local bladder. And in that particular scenario, heating the bladder is not going to be expected to make the chemotherapy work better. And in general, the combination of heat and chemotherapy is at this point considered investigational or experimental, in my opinion.
Okay, that makes sense. You spoke about some of the toxicities and side effects. Can you speak a little bit more about typical course of chemotherapy in terms of how long it would be, how many cycles, that type of thing?
Correct. So that's a good question. In general, for metastatic cancer, we give what we call cycles of chemotherapy. Most of these chemotherapies are given outpatient, usually once a week for 2 or 3 weeks out of 3 or 4. So typically with the combination of gemcitabine and cisplatin, we give a combination of both drugs 1 week, the gemcitabine the second week, the third week is a rest, and that entire treatment is termed a cycle. For patients with metastatic disease who are tolerating treatment and whose tumors are shrinking, we typically give 6 cycles of this treatment, and for patients in whom we give the treatment prior to surgery, we typically give 4.
Okay. And then in your last slide, you said that the current standard isn't good enough and you don't want to give the same talk in 20 years. Can you talk a little bit about what you see in the future of chemotherapy and kind of what's in the pipeline?
Sure. Bladder cancer or urothelial cancer is a environmentally caused cancer. In other words, it's typically toxins that are excreted in the urine, most commonly in this country from smoking, that lead to bladder cancer. And one of the things that we've learned over the last several years is that these kind of cancer have multiple different molecular abnormalities, and that when we do sort of some genetic analyses, that there isn't, one or two drivers that characterize all bladder cancer. There are multiple different drivers and multiple different genetic abnormalities. And as we begin to look at what these different genetic abnormalities might be, many of us are thinking that some of the drugs that are attacking these genetic abnormalities are likely going to be the drugs that we're going to use, and that it might be somewhat different for each individual cancer patient. Perhaps one of the most interesting things that has been published over the last year or so is some data from Memorial Sloan Kettering that suggested that the 2 or 5% of patients that have abnormalities in a pathway that we call the mTORC pathway may have tumors that respond to a drug called everolimus. And I think that we're going to begin to understand, and hopefully begin to understand, more and more of these kind of abnormalities and the drugs that may target them.
Okay.
Let me quickly answer Mr. Grieco's question, who's the one that here on the chat line looks like his phone came in and out. And just to summarize, I do not think that chemotherapy is appropriate for patients with T1, G3 localized cancer.
Okay. Thank you. For the next question, is doxorubicin alone effective in treating urothelial cell cancer?
Probably not. Doxorubicin by itself is not particularly helpful, certainly not for patients that where the cancer has spread. I think that in patients whose initial treatment has been ineffective, and who did not receive doxorubicin is one of many drugs in which one might be able to get a little bit of shrinkage, but by itself in patients who have had no prior treatment, that's not something that I would recommend.
Okay. Next question is, where does bladder cancer most often metastasize?
So the initial place that bladder cancer metastasizes is to the lymph nodes in the pelvis and also to the lymph nodes in the back of the abdomen. After that, it can metastasize to many different areas, including the liver, the lung, and the bone as the most common.
Okay. Just taking a look at the questions on here. Can you speak a little bit more about how the oncologist would determine if the chemotherapy's been effective in treating a case of bladder cancer?
Sure. So for patients who have metastatic cancer that has spread, we usually make that diagnosis with some kind of CAT scan typically. And we typically repeat those CAT scans every 2 or 3 cycles to determine if there's been any tumor shrinkage. And that's really what we're looking at, usually from CAT scans, obviously also from how the patient is feeling and examinations and some laboratory tests. But with this disease, the primary manner in which we assess whether the treatment is doing any good is through things like CT scans.
Okay. That makes sense. Well, that looks like all the questions that we have for now. I'd like to thank you very much for speaking tonight, Oh, wait, we have one more question. All right, we'll do one more question. Says, if the Zofran drip that is given prior to chemotherapy causes extreme constipation, can it be cut back or eliminated if the patient chooses?
Well, absolutely. I mean, Zofran is an anti-nausea medication, and many of the drug treatments, especially the cisplatin-based treatments, can cause a fair bit of nausea, and medicines like Zofran help prevent that. But certainly there are other anti-nausea medications in that same class, including things like Kytril, for example, and other medications. And if a patient is having significant side effects from something like Zofran, we would certainly think about switching to a different anti-nausea medication.
Okay. For the next question, after a serious reaction from 2 BCG treatments, okay, and no cancer visible for 6 months, high-grade tumor has returned, now using Valstar. I guess maybe this person wants you to comment, even though it's talking more about intravesical therapy.
Yeah, so from an intravesical therapy standpoint, if it's high-grade cancer but it's not invasive, or if it's T1 disease, then one could think of something like Valstar. It is effective, in some patients long-term. The majority of patients do not have long-term benefit and may need a cystectomy eventually, but certainly it makes sense to try something like Valstar.
Okay. For the next question, at what point before metastasis do you recommend that a patient have a radical cystectomy?
And this really sort of gets back to the issue of, if a patient has non-invasive cancer that has recurred, at what point would one begin to think about cystectomy? And I think that once one develops T1 disease or what now constitutes invasive disease, I would seriously begin to think about the cystectomy. The issue is that patients with T1 disease will often have a more extensive disease on surgery, and if the intravesical therapy or the therapy we give in the bladder is ineffective, the risk of the cancer growing and spreading and metastasize increases. So the longer one waits with ineffective intravesical therapy, the higher the risk for metastatic cancer.
Okay, and it looks like we have time for one more question. I know you spoke to this generally before, but maybe if you could expand a little bit on what new treatments are on the horizon for metastatic bladder cancer.
So I think there's a couple of interesting things. I talked about some of these genetic abnormalities that I think are drivers of disease, and I think that many of these genetic abnormalities have drugs that might attack these abnormalities. Certainly these include various what we call kinase inhibitors. These are against various growth factor receptors, including things that are being looked at include FGFR receptor inhibitors. Then there are sort of drugs that inhibit the signaling pathway for some of these growth factors. These include things like, PI3 kinase inhibitors and what we call TORC inhibitors. I think that there is interest in looking at whether some of the newer immunotherapy regimens, including drugs that target a immunotherapy regulatory protein called PD-1, they are looking interesting. Whether they're going to be effective or not in bladder cancer remains to be determined. And then there's a host of other sort of new targets that have been identified and simply not tested in this disease. So I think that there's hope for new treatments and new ways of looking at this, and certainly many of these are being looked at various centers.
Okay. Well, thank you so much again. Really appreciate you taking the time to present tonight. Just want to let everyone know that we have the Walk for Bladder Cancer coming up on May 4th. Please feel free to contact us at walk@beacon.org or go to Beacon website, beacon.org, for more information. And once again, this webinar is being recorded. The recording and slides will be available within the next 2 weeks. Thanks so much, everyone. Have a great night.
Thank you.